Yeah,
Yes.
thank you. We'll start with one, two for a question. Question. Yeah, how often are you able to get the effect with a single procedure, and how many times do you have to do a repeat in your experience?
Yes. You mean this? In which cases I do 2 sessions? Yeah. Yes. If the nodule volume is above 30 ml, 80% of these nodules need the second seasons. But if I do second seasons, I do it after 1 year. But most of these big nodules, ablation indications is cosmetic scores. Patients have at the skin cosmetic. If we resolve the cosmetic score, mostly I don't do a second season in these cases.
Okay, that's good. Also, the cutoff of 30 mils. How do you do that calculation? Because the size, you have gone even up to 4 centimeters.
Yes, 30 ml. The machine measures this. I measure the 3 dimensions, and you can calculate itself. If you measure 3 dimensions, and then the machine are in every ultrasound machine. If you measure this, they calculate the volume.
Okay, you are able to achieve the complete ablation from one puncture point most of the time. How often do you have to do second?
One point. One puncture point is mostly enough. Yes.
Okay. How many have you had to use backup surgery in case this doesn't work? Have you had to do that, or you just do a second session?
I have never backup surgery because it's mostly of these patients are cosmetic patients. Important is in the beginning, I have some complications. I must say this honestly. In the beginning, I ablated every nodule. And most of the nodules was very stiff, and there don't shrinkage, and the patient was not happy, and he goes to surgery. But if we select right nodules, soft nodules, spongiform or nodules liquid rich or hypervascular nodules, in those nodules, mostly the shrinkage rates are in 6 months between 80 and 90%. And I think it is a very good result. 80 and 90%.
Long-standing nodules with calcification, those will not be suitable.
Yes, too much hyperechoic and with macrocalcificated nodules are not good candidates for ablation. In this nodules, I don't try to touch.
What about bleeding? Have you had any complications with bleeding because of the?
Yes, thank you for this good questions. Thank you. Yes, sometimes in hemorrhagic nodules, in venous hemorrhagic feeding nodules, sometimes at the puncture of, we have some bleeding sometimes in fine needle aspiration in this type of nodules. But if we bleeding, we don't stop the procedure, we continue because it is a heat. It's like surgery, cauterizations, what you do. In these cases, sometimes you aspirate the hemorrhagic fluid, but it's filling again at ablations. In these cases, I learned this technique from Spain, from Professor Juan Garcia. I pressure with the transducer to the nodule and ablate it. Then mostly if I do with pressure and with ablation, sometimes in these cases I increase the watt from 30 to 50 watts more and don't do moving shots, stay there. And mostly the hemorrhage bleeding are stopping there in these cases.
Okay. Present. Okay. One more question I had is, okay. Anybody else?
So patient compliance with investigation, local anesthesia scheme.
Yeah, so the local anesthesia protocol will be, well, can you explain? You inject under the skin first and then into the deeper space.
Yes. Yeah, I use lidocaine mostly, and I inject lidocaine between the strap muscle and thyroid capsule. If I inject in this area, it separates the strap muscle from the thyroid capsule, and it makes it around a perithyroid anesthesia. And patients at the procedure don't feel any pain. And capsule is sensitive for pain, but thyroid parenchyma is not sensitive for pain.
And post procedure, with your protocol, they usually pain.
Yeah, after post procedure, most of the patients say me that they have 1 or 2 days problem at the swelling. Sometimes it is related with the edema, and therefore I order them anti-inflammatory painkillers like diclofenac sodium, but they have no pain. Sometimes they have some small voice changes after lidocaine injection, but no pain. They directly go after 1 hour and they continue their normal life. They can after 1 hour eat anything, take a shower, because we do everything from a small needle point.
Okay. The question is about hydrodissection. What is the thickness of the gap that you aim for between the thyroid and the vascular structure of the nerve? You have any particular thickness, or just varies from?
Yes. I don't do the hydrodissection with the needle. If I go between the, except I give example between the carotid artery and thyroid nodule, I push the fluid. The fluid separates between the two anatomic structures, and it is very easy to do. If any physician do a fine needle biopsy, he can do hydrodissection. It is very easy. It looks very interesting first time. I know it. Mostly physicians say do, but it is very easy to do. If you do FNA, you can do this. It's only you go with the needle and pressure of the fluid that you inject separate the structures. I use normal 21 gauge normal syringes. With this I do, not with thin needles, because with thin needles you cannot give a good pressure to hydrodissection. I use normal needles that we use in intramuscular injections, 21, 22 gauge.
Okay, thank you. I also had one question. Do you see a lot of autoimmune thyroiditis? We have this Hashimoto. It's quite common in setting now. Either they occur along with nodules, or they may be primarily Hashimoto thyroiditis. Is there any indication there, or any special precautions because they are quite vascular?
Yes. In Hashimoto thyroiditis, I don't try to touch, because patients are, inflammations. At the procedure and after procedure, this patient group feel always pain and they are not happy. And in this patient group, after ablation, we have very high incidence of edema. Therefore, I don't try. But some cases, we begin science 2 years in my clinic in big thyroiditis or in Flonjuan Guaters. Sometimes we do in these cases thyroid artery embolization. Sometimes we do this for treatment. We can do, but in Hashimoto thyroiditis, I don't prefer thyroid ablation.
Okay. Yeah, thank you. We'll conclude this first session. And
okay.
yeah, would you like a break, or you want to go straight?
Yeah, it is very short. Breast microwave ablation season is very short.
Okay. Please proceed.
Yes. Okay. Breast fibroadenoma microwave ablations. Normally, conventional excision is safe and effective for managing breast fibroadenomas. However, for large fibroadenomas, obvious scars due to extended incision or misshapen breast resulting from the collapsing cavity may impose physical burdens on patients with cosmetic expectations. To aiming to achieve a balance of therapeutic efficiency and cosmetic certification, alternative techniques are in rapid development, and one of them is microwave ablations. Here's a paper from China, and this is the volume reduction for bigger than 2 centimeters benign breast lesions after ultrasound-guided microablation with a minimum of 12-month follow-up. As we see, after ablation, after 12 months, we have a shrinkage rate at 80%. And what we use in this is we have a mixture of 2% lidocaine and saline into the surrounding breast fibroadenoma. And the goal is to achieve a liquid isolated region to protect the skin, pectoral, and areola from thermal injury. Here is an example. This is a 3 centimeters breast fibroadenoma. After ablation, we see the difference in the echogenicity, but in every fibroadenoma cases, after ablation, after the first month, we see increases in the size of the lesion. It is related with the edema in these cases. But this is before ablation, after 1 month, but after 3 months, it's go to shrinkage, and after 6 months, it is very small. And here the same cases before and after, mostly of these cases are totally resolved by ultrasound imaging after 1 year. But after 1 month, we always see edema and increase by the size of the nodule. This is another big fibroadenoma. We do the same things what we do in thyroid ablation. We inject under the skin lidocaine and saline or dextrose mixture, and we do the same thing between the pectoral muscle and nodule, and then we begin with the moving shot technique, the same technique to ablation. Here is an example. This is a 5 centimeters big fibroadenoma in enhanced MRI, breast MRI. And after, this is before and after ablation, you see, we don't see any enhancement. We totally ablated, and this is from the sagittal. And the important thing, after 6 months, if we scan a new breast MRI, we don't see any fibroadenoma here. It is totally resolved. And here is another case, 27 millimeters well-controlled lesion, and this is a fibroadenoma, and after ablations, you see, we don't see any enhanced lesion. And this is before 2.5 centimeters fibroadenoma, and only after 6 months, you see, we can see it very difficult from the parenchyma. Breast fibroadenoma ablation is very short, what I say, because always what I explain in thyroid ablation are the same hydrodissection and same moving shock technique. Only the problem in breast fibroadenomas are, if we see at the fibroadenomas like thyroid nodules, macrocalcifications, or it is too much stiff. In these cases, we don't do ablation. But in young women, in hormone positive lesions, in fibroadenomas, in these cases, the volume reduction rate is between 95 and 100%. It is very effective and without any cosmetic problem, with no scars. Therefore, in breast fibroadenoma, we can do this. It's this line.
Thank you. Thank you for the introduction.
Yes.
Yes.
Just a question about what about multiple lesions are also doable, because we have some with multiple
Yeah,
on
we
both
can
sides.
do. Yeah, if the patient don't see discomfort, we can do. But if the patient has 6, 7 fibroadenomas, I don't do this. I prefer to do in 1 or 2 big fibroadenomas.
Okay.
Yes.
Thank you. Any more? The temperature settings are the same. Any difference in technical for breast and thyroid?
Same. 30 watts. What we chose is 30, and the temperature is same 60, 80. We never do like liver ablation. We don't fix the antenna and wait there, because if we do this, we have carbonization. We do the same thing what we do in thyroid nodule. We use the moving shot technique, and the goal is only totally ablation with the moving shot technique.
I know that for some older women with cancers who have high comorbidity, they've tried cryoablation as a non-operative technique. Have you done this for old patients in malignancy?
Yes, we do it, but I always, in malignancy, prefer cryoablation. Is more safe. In Turkey, the national insurance system don't cover it, cryoablation in the university hospitals. Therefore, we cannot use it. In some patients, in old patients, we sometimes that cannot have a surgery. We do it, but in malign lesion, I have no experience so much. I don't do it.
Okay. Also, regarding thyroid nodules, again, do you have any specific guidelines on which technique you use? You know, we have percutaneous ethanol, we have radio frequency and high frequency ultrasound. So where do you think microwave scores over the other?
Yes, thank you. Ethanol ablation, we use ethanol ablation in pure cystic nodules. In pure cystic nodules, I do the same thing. I only use ethanol, alcohol ablations. I use, but in nodules, semi-solid nodules that have solid compartments, I use the both techniques. I firstly use ethanol ablation, then I ablate it with thermal ablation with RF or microwave. In why we must use microwave and what is the advantage to RFA? My experience is most of the patients that we ablated have big nodules, 4-5 centimeters. We never ablated 1 centimeter nodules or 2 centimeters. All the patient group have big nodules. And if you ablated this with RFA, example, the ablation time is 15 or 20 minutes. If you ablate the same nodule with microwave, it is only 5 minutes. It is very fast. Second, I explained this in the video. The heat in microablation go not forward 2 millimeters. It go always back. This advantage in narrow ablation of narrow areas, because we have in thyroid we work in a very narrow area. Therefore, it is good for avoid of thermal injuries. And RFA works with according to the impedance of the thyroid nodule. In hemorrhagic nodules, in semi-solid nodules, RFA sometimes don't work. But in microwave, the internal structure of the thyroid nodule is not important. It ablated every nodule. This is very important. Sometimes I have last week a case, it was a pregnant woman. She have parathyroid adenoma, and while she have hypercalcemia, she have a very high level of hyperemesis gravidarum. I ablated her with microwave ablation. but you cannot ablate pregnancy with RFA because we use ground PETs. We have an ionic current in the body. Or if a patient have a heart prosthesis, a pacemaker, or a teeth implant, or a knee prosthesis, in these cases, you cannot use RFA. But microwave is safe in these cases. Therefore, in these cases, I prefer microwave.
Thank you. And your experience with high-intensity focused ultrasound, do you have any thoughts on that?
No, in my country, we have not HIFU. I have no experience.
Yeah, so I think we have run out of questions. We want to thank you very much for your time and effort. It was very interesting. Yeah, and I'll be in touch. So thank you once again. Thank you, Julie, for organizing and the
Dr. Paul, I will share my these presentations with the ECHO team, and they will share this presentation for you. Maybe you can use it for your presentations or for lectures, doctor.
Thank you, very kind of you.
Thank you, sir.
Okay.
Thank you, sir. Thank you, Dr. Bulent, Professor Paul. Thank you for your team, and we hope that one day we can invite Dr. Bulent to visit India, and we will have more, chance to communicate that. Okay, sir. Thank you all. Thank you all, and have a nice day, sir. Have a nice day. Thank you, Dr. Bulent. Professor Paul, thank you so much.
Okay.
Okay.